Okay, I would like to introduce Dr. Asa. She is world-renowned pathologist that is working in Cleveland right now, but used to work out of Toronto. And she is going to do a presentation for us on the pathology and genetics of acromegaly.
So thank you, Deanna, and thanks to the group who organized this for inviting me here today. I'm going to just start by asking a couple of questions. And I don't want the docs in the audience to answer, just the patients, please. Patients and family. How many of you know your endocrinologist? Lots of people. How many of you know your neurosurgeon? How many of you know your pathologist? One hand goes up. Usually there are none. That's great. Okay, so let me first start with a couple of housekeeping items. First of all, you've got a handout of my slides, and there's a lot of material in the slides, and I'm going to try to give you the 35,000-foot view of this, and I'm not going to go through all the gory details because you don't need to know gory details. But I want to give you perspective. And on the handout, there's room for you to make some notes. And if you have questions, I am more than happy to answer them. I'm going to be around all day. I'm going to be here this evening. And so anybody who has questions, and if not, Deanna has my email address. I'm happy to share that. Anybody can email me and ask questions. My slides start with a couple of housekeeping items that I usually put in just so that everybody knows. In medical world, we usually kind of say what our disclosures are. I do work with some companies, but none of them have anything to do with acromegaly. They're all about digital pathology, which you don't even have to ask about today. So I'm not conflicted in any way, shape, or form. But my learning objectives are important for you, and what I really want you to understand is what is pathology and how does it matter to you as patients? I want you to understand the fact that as a pathologist, what I do is try and help the clinicians who are caring for you understand the biology of your disease so they can give you the right treatments. And I'm also going to just very quickly try and let you know that there are some genetic changes in pituitary tumors. Some of them are inherited, some of them are not, and they impact the way the tumor will behave. So with that background, I want to just start with a little bit about what is a pathologist and what do we do. Don't read what's on the slide. The slide is meant to just make you say, oh my God, there's like so much information there. And the answer is, yeah. A pathologist's job is to analyze tissue or cells that are removed from a patient who is sick to try and understand what's wrong. Is it a cancer? Is it a benign tumor? What kind of tumor is it if it's a tumor? Is it maybe not a tumor, it's an infection or an inflammatory process that needs to be treated in a completely different way? Or maybe it's a cyst that you can just drain fluid and it will collapse and be cured. So the role of the pathologist is to take the data from the clinical examination. We get the background history and the findings on the physical. We get pieces of tissue or cells. We look at them in the microscope. We analyze them using biochemistry or biochemical techniques to try and identify what is going on. And then we tell people like Dr. Cusimano and Dr. Johnson, your patient has this particular disease, and that should guide the treatment for that patient. So when a patient has pituitary surgery and I get some tissue, I have to think about all the things that are on this slide as being potentially what is wrong, and I'm going to give a diagnosis that's going to make the answer clear. What I'm going to talk about today is really only one part of this. And so the only part I want you to remember is the very first two lines, pituitary, what we used to call adenomas and carcinomas. And the reason is I'm talking about acromegaly. And most acromegaly is caused by a primary pituitary tumor. I will at one point wander a little bit into some other areas because there are other causes of acromegaly, but they're exceptionally rare. Now, one of the things that we've been talking about today is the whole issue of, is this a rare disease? And if it's rare, how rare is it? And it's something that we have all struggled with in medicine, and I've been studying the pituitary for longer than I care to admit. Now I'm going to show my age, but I've been doing this now for almost 40 years. It's a long time. And I remember when I first started, I was taught in medical school that acromegaly is really, really rare, and pituitary tumors are very rare, and this is so esoteric. But I got really interested in the pituitary at a very early stage in my training, and I had the really good fortune of working with somebody who studied pituitary tumors. And so from the earliest days of my medical training, I have known that acromegaly is not quite so rare. I look around this room and I say, oh my God, I used to tell students, acromegaly is all around you. You just have to see it. You have to think of it to see it, right? So I've been working with people like you for many years. I'll start with another confession or disclosure. This is probably the most important disclosure. I'm actually married to Dr. Asa, and so you can imagine what our dinner table conversations are. So, we've always talked about this with patients, and he started a pituitary support group back in the 1980s, back in California when he was training. And we've worked with the Pituitary Network Association for many, many years, and they actually came to us and said, are we going to dispel this myth about the rarity of pituitary tumors? And so we wrote this paper. We did a study back in 2004 where we analyzed all the data in the literature to try to come up with some idea of how common these tumors are. And that was the first study that kind of made people stop and say, oh, maybe. We only analyzed old literature. And I knew from doing autopsies, for example, that pituitary tumors were commonly found in patients who had never been diagnosed, some of whom had a history of osteoarthritis and sleep apnea and died of a heart attack. And it was obviously acromegaly that had been missed, right? Anyway, since then, all of the studies on the bottom of this slide have all shown that actually pituitary tumors aren't quite so rare as we used to say. And that's a good thing. We now are aware, and awareness is always the first step in being able to fix a problem. Now, I want to bring up another issue, which is probably more politically charged, but it's all about the spectrum of this disease and how we should be thinking of it in the context of medicine and classification. These are all pictures from books and papers that I've written, showing on the far left a tiny little pituitary tumor, which you can see right here, right? In an MRI, a little hole in the gland. And just to the left of it is actually the autopsy correlate of an incidental finding. You can see a pituitary gland, and there's a little white circle in it, and that's a tumor in the pituitary. Now, those tiny microtumors can be things that are just found incidentally, but they can also be functioning tumors. And the most common ones make prolactin, and they're known as prolactinomas, and they're actually quite treatable. The one that is actually in that picture, though, killed that patient. She had Cushing's disease, and she died of the complications of undiagnosed Cushing's. So we're talking about a tumor that can be a tiny little thing that's meaningless. It can be an incidental finding at autopsy, or it could be the cause of death. And as I said, I've seen this in patients who I now know had acromegaly, but were not diagnosed. In the middle is actually an acromegalic patient who has a tumor that's infiltrating the cavernous sinuses. And on the far right is a giant tumor that's actually growing up and invading the brain and causing brain dysfunction in a patient who had no hormone excess but had this large invasive tumor. And the correlate of that at autopsy, this is actually just a picture of the skull, the base of the skull after the top has been removed. If you just cut the head like this and take it off and look down, you can see this big red pituitary tumor herniating up, okay? These are all pituitary tumors, and they range from microtumors to giant tumors. They range from silent tumors that don't secrete hormones in excess to tumors that cause acromegaly and Cushing disease, both of which can be lethal if not treated. So I see these as the tissues, right? Let's talk about terminology. This is where the politics comes in. Most of you have had a diagnosis of a pituitary adenoma. And this is a terminology that we used, and I have used for almost 40 years. As I said, I started this almost 40 years ago, and until about 5 years ago, I always talked about pituitary adenomas. But we discovered that the term adenoma creates a dilemma, both for patients and for doctors. And the reason for that is that an adenoma, by definition, means a benign tumor. That's what the word means, a benign epithelial tumor. And a benign tumor is something, again, by definition, if you look things up in the dictionaries, it has no impact on the health or longevity of the patient. How many of you feel that your disease has had no impact on your health, quality of life, or longevity? Anybody want to put up their hand? I'm looking for one hand. No. We had a patient who was denied therapy for this tumor that was growing up into her brain because what she had was a benign tumor. And we said, this is not right. None of our patients believe that their disease has no impact on their health or their longevity or their quality of life. We need to come up with a better term. In medical terminology, there's adenoma, which is a benign lesion that doesn't have any impact, and then there's something called carcinoma, which is a malignant disease that spreads and kills you. And the challenge that we have is we're dealing with a disease that tends not to really metastasize like carcinomas. We don't really want to call it a malignancy, but we want to convey the concept that this is a disease that has two major characteristics that can really alter your life. One is that it can secrete hormones in excess that can really hurt you, and the other is it can invade. And when it invades, it impacts your vision, your brain, your carotid arteries that keep your brain alive. And even surgeons like Dr. Cusimano, who's a genius when it comes to pituitary surgery, cannot always resect these tumors so that we can cure the patients. So there is precedent for this, and that is actually, ironically, in the same field as pituitary. It's in the rest of what we call the neuroendocrine system. Now, the pituitary is one gland that is part of a system of cells dispersed throughout your entire body that make peptide hormones and regulate the rest of the body. You have these cells in your pituitary, you have them in your parathyroids, you have them in your thyroid, in the gut, in the lungs, in the pancreas, and throughout the entire GI tract, all the way to the rectum. And we also have them in paraganglia that regulate your autonomic nervous system. And all of these cells are called neuroendocrine cells. And they have specific characteristics that are listed on the slide. You don't need to know specifically what they are, but the markers that we use for neuroendocrine cells are the same in all of these different tissues throughout the body. And all of these cells give rise to tumors that can be relatively benign, and they may be incidental findings that never hurt you, but sometimes they grow and sometimes they become very aggressive, and many of them will secrete hormones in excess. If they happen to be in the GI tract, they give you a lot of diarrhea and flushing, kind of like pituitary that secretes hormones in excess and gives you other features like having your bones grow too much and having rage and uncontrollable rage and doing all kinds of horrible things, right? So in those other cells, we call their tumors neuroendocrine tumors. And being a neuroendocrine tumor means that you have a spectrum of behavior. You can be a small incidental finding, or you can be a very rapidly growing and invasive lesion. You will secrete a hormone in excess potentially that might give you some added effects. And interestingly, the treatment that we use for neuroendocrine tumors everywhere in the body is surgery, followed by somatostatin analog therapy, followed by other drugs like temozolomide or Captam, maybe radiation, and maybe a peptide-directed targeted radiotherapy, which we call PRRT. And all of these are used for patients with neuroendocrine tumors everywhere in the body. And so we made a proposal a few years ago and said, let's change the terminology. Let's call these pituitary neuroendocrine tumors, which scientifically is an accurate characterization and allows people to understand that these can be relatively indolent, but they can be aggressive. And when they become aggressive, we will use a series of targeted therapies that are directed for neuroendocrine tumors. And they're the same pretty much everywhere in the body. This was one of the pictures that we used to talk about this disease. And this is actually an MRI of a patient who's got a pituitary tumor. You can see this huge white glob growing up into this patient's brain and destroying their brain. Now, by old terminology, we would have had to call this a pituitary adenoma. I can't imagine that this patient would want to be told that he had a benign tumor that wasn't going to hurt him. He's lost half his brain. He can't see. He's blind. I don't even want to get into the side effects of the hormone excess, right? So I was lucky to be involved with the WHO in the last year, and we've actually, we were asked to give a proposal on terminology change, and we proposed this change in nomenclature to pituitary neuroendocrine tumor. And during the presentation, we were asked a number of questions, and one of them was, can you distinguish a tumor that will metastasize, which rarely happens in the pituitary, from one that does not metastasize? And the answer to that is an unequivocal no. Any patient who has ever had a diagnosis of pituitary carcinoma, everyone in the literature has had first a diagnosis of pituitary adenoma when they had their first surgery, and then when they did develop metastatic disease, the diagnosis was changed to carcinoma, but the tumor looked exactly the same. So by scientific and medical criteria, I was told by the head of the WHO, there is no such thing as a metastasizing adenoma. So that diagnosis must be incorrect. Now, the reason I've spent a lot of time on this is because some of you may be aware that this has created a tremendous controversy. And there's a lot of discussion going on about whether or not we need to change the terminology. There are a lot of people who still like this term adenoma. There are some people who understand that there's a need for change. I would love to hear from you now that I've given you some background, how you all feel about it. As I said, our impetus was initially to ensure that patients who had aggressive disease would have access to the treatments for an aggressive tumor that are oncologic therapies. So, as I said, please give me some feedback. I hope I've explained it clearly for you. Now, the other job that I'm going to do today is to try to help you understand the classification of these tumors. And when it comes to pituitary tumors, we have multiple classifications, including functional ones. Today we're talking about acromegaly, which is growth hormone excess. There's structural. Dr. Cusimano, before he operates on anyone, is going to want to know from the radiology, is this an invasive tumor or a non-invasive? Is it a recurrent or a primary tumor? What's the growth rate? I, as a pathologist, look at the morphologic classifications of these tumors, and of course, the endocrinologists want clinical pathologic correlations so they can treat the patients. And we also want to be able to determine responsiveness to medical therapies. And the classifications have grown in different ways. Radiologists have developed theirs, surgeons have used primarily radiologic classifications, endocrinologists focus almost entirely on function. And what I want to do today is present to you what is the new WHO classification of different kinds of pituitary tumors. Now, it might look too complicated for you because this is a huge chart. But the important thing is that there are actually 3 main lineages of cells in the pituitary. And the one that we're going to talk about is in the middle, which is the PIT1 lineage, which is actually the cells that make growth hormone and cause acromegaly. But what I want you to think about from looking at this chart is, this is really complicated. How am I going to put all this in the context of what I understand? What I really want you to walk away with is this one simple concept. Acromegaly is not one disease. As I look around this room, I see the possibility of at least 6 or 7 different kinds of disease. Each of you has a different tumor type, which gives you different manifestations. Some people are tall, if you don't mind. Some people are not so tall. Some people have very florid acromegaly, and some of you, your colleagues in the room are looking around saying, well, you're lucky you didn't get it as bad as I did, right? Well, there's a reason for that. Part of the reason may be simply I was picked up later, but part of it is actually just what the tumor is, because in fact, there are 6 different kinds of pituitary tumors. How many of you have heard about your tumor being either densely or sparsely granulated? A few hands go up, right? Okay, so that was the start of the story. We as pathologists recognized that sometimes these tumors had lots of granules and sometimes they didn't. And we started to see that the ones with lots of granules happened in patients who had very florid acromegaly, and the ones that were sparsely granulated were in people who didn't quite look so acromegalic and their blood levels weren't quite so high. Now, in your handout, there's going to be a whole bunch of pages, which I'm going to go through quickly. I don't want to spend too much time on this because, again, it's for your own knowledge and it's in the handout, but there is this classic densely granulated tumor, which is what was originally described more than 150 years ago as the cause of acromegaly. This densely granulated tumor in cells that are called somatotrophs, which are the normal growth hormone producing cells, is a classic tumor that gives rise to very florid acromegaly. And because of that, it tends to be picked up when it's a slightly smaller tumor. If you're really lucky, it can be cured because it's still intracellular if whoever has diagnosed your acromegaly did so early on because of the florid features. Again, I'll make a little sidebar here. There are clinicians who are very good with hearing, and there are some who are deaf. And if your clinicians are deaf, they won't recognize this until it's a big tumor because they just are unaware of acromegaly no matter what, right? But in relatively well-educated groups, these tumors tend to be picked up earlier when they're smaller because they cause florid acromegaly. They tend to occur in younger patients. They tend to be associated with a very specific genetic mutation, which I'm going to talk about more in a few minutes. And because of that, they respond very well to somatostatin analog therapy. Their counterpart, which is sparsely granulated, is a different tumor. It's not quite so hormonally active. And so because of that, it tends to be a lot bigger when it's diagnosed because the acromegaly doesn't show up so much. These patients have what we call big tumors and small acromegaly. Because of that, the patients are about 10 years older on average when they're diagnosed because they've had 10 more years to grow. And except for one, they tend not to have mutations, but there is one subtype which is in people who have a familial disease called familial idiopathic pituitary or isolated pituitary adenomas. These patients are younger, but that's because they have this genetic mutation and we pick it up earlier. These tumors don't respond very well to somatostatin analogs, and that's because we know that the genetics is completely different. Now, there are variants of all these different tumors. So some of you may have had a tumor that not only makes growth hormone, but also makes prolactin. Prolactin is related to growth hormone. And in the normal pituitary, there are cells that make both growth hormone and prolactin, and they're called mammosomatotrophs. Mammo means breast, they stimulate the breast, and somato means growth, body growth. So mammosomatotrough tumors are densely granulated. They're just like the densely granulated somatotroph tumors, but they also make prolactin because they're from this other cell type. And these tumors also tend to be small tumors with big acromegaly, but they also have hyperprolactinemia and some breast effects. There's a counterpart to this, which we reported a number of years ago, which is a mature cell that looks just like a mammosomatotroph, but in addition to making prolactin and growth hormone, it also makes TSH. Now, I'm not going to ask for a show of hands, but some of you may know a patient who's had acromegaly who also had hyperthyroidism, and this tends to be the cause of that disorder. But there is another counterpart, which is from an immature cell related to that same cell lineage, but because it's immature, it's a little bit more aggressive and doesn't behave itself quite so much. And these tumors can make growth hormone, prolactin, and TSH, but they can make them in very small amounts. They can make 1 or 2, maybe none of those hormones, but they're from that same cell type. And these are bad tumors. These are tumors that tend to be pretty ugly under the microscope. I can tell you that picture is an ugly picture. And they tend to be fairly aggressive tumors that are extremely infiltrative, and they infiltrate down. They infiltrate into the cavernous sinuses, but they infiltrate into the nose as well. So this is a not so good tumor to have, and we've seen that this happens to be more common in younger patients. So I hope I'm getting the message across that acromegaly is not one disease. It's actually a lot of diseases. There's one more tumor type I'm going to mention, which is the acidophil stem cell tumor. This is rarely associated with acromegaly. It's much more of a prolactin kind of tumor, and it has what we call fugitive acromegaly. You have to have a really high sense of suspicion to actually go and measure IGFs and say, gee, I think that patient might have acromegaly, and when you check it, yeah, it's elevated. All of these are tumors that behave completely differently. They respond differently to different drugs, and that's why they're important. So let's go back to that classification, and I'm going to make your life a little bit easier because now we're not going to look at all the other tumors. We're only going to talk about the ones that are associated with acromegaly, but still you can see that there are 6 different kinds of acromegaly. I'm going to make your life just a little bit more complicated so you don't walk out of here and say, I think I understand this now. There are also mixed tumors, and there are tumors that don't read the book. So there are sometimes tumors where you get 2 tumors growing together. And the most common one is actually in acromegaly, where you have a growth hormone tumor and you have a separate tumor making prolactin, but they're growing together in the same gland. But every once in a while, we find something really weird, like we can have a growth hormone tumor growing with a gonadotroph tumor or a Cushing's tumor. So I was just laughing because Dr. Johnson gave a really great talk today, and she said patients with acromegaly don't have ACTH excess, and I'm thinking of that, I just recently had this really weird case where this patient who had acromegaly had a microcorticotroph tumor associated with it, so she did have both, but that's really, really rare. It does happen, just so that you know, not all the tumors read the textbooks. And then there's occasionally a patient who actually has a tumor of their hypothalamus. And again, Dr. Johnson very nicely showed you how important all that signaling is and the regulation from the brain to the pituitary to the liver to make IGF-1. Sometimes the hypothalamus misbehaves and creates a tumor where those hypothalamic cells overstimulate the pituitary and then cause acromegaly. Again, rare, but it occurs. And the most rare of all is one in which you think the patient has acromegaly and you do an MRI and you say, that pituitary is a little big, but I don't see a tumor. What's going on here? And it turns out that hopefully you don't have surgery. We'll try and make this diagnosis beforehand, but unfortunately, I have seen patients who actually end up with surgery, and I say, no, there's no tumor here. This is hyperplasia. It's reactive, secondary. And it turns out that the culprit is somewhere else, like the lung or the pancreas, which can make growth hormone releasing hormone to stimulate the pituitary to cause acromegaly. You take out the lung tumor or the pancreas tumor. Both of them, by the way, are neuroendocrine tumors, but they're lung or pancreatic neuroendocrine tumors, and then you cure the acromegaly that way. Okay? So we have these 6 different kinds of tumors as the common ones. We won't talk too much about those esoteric ones. I want to talk a little bit about the genetics because each of them has different genetic profiles. And when we talk about genetics, again, I want to make sure that I lay the ground for this properly. We mean different things when we talk about 2 different kinds of genetics. There's germline genetics, and then there's tumor genetics. Germline genetics means you inherit a gene that makes you predisposed to developing something. Germline genetics gives rise to inherited disease. Your mother or father may have had something, you get it, your kids are at risk, right? Sporadic disease is completely different. You're a normal person walking around, something in our environment causes a problem, you get a genetic mutation in a cell, it creates a tumor, and that tumor has a characteristic reliant on that gene, okay? Germline predisposition is very rare in acromegaly, but it does occur. And sporadic disease does have very clear genetic alterations. So let's talk a little bit about the genes, and what's really interesting is that sometimes the genes are the same. You can have the same gene mutated in a sporadic tumor or in a germline disorder. So what are those genes? Well, there's a gene called MEN1. MEN1 causes multiple endocrine neoplasia, type 1, which gives, as one of its manifestations, pituitary tumors, and interestingly, the commonest ones secrete growth hormone. So if you have acromegaly, you may be a part of a family in which many people are predisposed to getting acromegaly. Not everybody who's predisposed will get it, but people may have parathyroid disease or pancreatic disease, neuroendocrine tumors in both of the other sites. They may have adrenal lesions. They may have other cancers in other sites associated with this genetic abnormality. We don't usually see sporadic loss of MEN1 in pituitary tumors. The most common sporadic event is this mutation of this gene called GNAS. And that's, I did mention it earlier, in the densely granulated tumors. This is the commonest molecular alteration that we've ever found in pituitary tumors is activating mutations of the GNAS gene, which make the cells hyperfunction, give you acromegaly, and make you exquisitely responsive to somatostatin therapy because somatostatin inhibits the effect of this GNAS mutation. There are a couple of others I'll point out. Many of these are quite rare, but AIP is one I do want to mention. The AIP gene, as I said earlier, causes this, this germline hereditary disease in which pituitary tumors are very common. And it tends to be growth hormone secreting tumors, and they tend to be of the sparsely granulated type. And that is the most common genetic alteration that's been found in people with gigantism. And then just at lunch, we were talking about young people diagnosed with very early onset gigantism at the ages of 2, 3, and 4. They usually have this very rare pediatric disease called X-linked acrogigantism, or XLAG, due to a mutation in the GPR101 gene. So I think, I don't want to go into a lot of medical stuff, but I want you to grasp that there are some alterations that we can target. They play a role in the development of the different tumor types, and it's important to think about the possibility of familial disease in the right context. I do have a couple of pictures in the handouts. I don't really want to go into too much detail for anybody who's interested in the science. This is the logic behind the way these genetic mutations impact cellular function and how we can actually target them with specific drugs, why certain drugs work on certain tumor types better than others. For example, why somatostatin analogs are so important for some tumors, whereas others are probably better candidates for things like pegvisomant therapy. So I want to just again point out, this is GNAS mutations are found in virtually all of the densely granulated types of tumors. I just wanted to make that point, which is again coming back to why the pathology is so important. So in terms of planning therapy, what the pathologist reports is really what the clinicians should be looking at when they start to decide, are we going to go with somatostatin therapy? If the patient was pre-treated with somatostatin and didn't respond, you can sometimes get the explanation from the pathology. When is it important to think about adding pegvisomant? When should we start thinking about dopamine agonist therapy? Is this a tumor that's making prolactin? Maybe prolactin inhibition will help in tumor control. And of course, if unfortunately you get a diagnosis of hyperplasia, you better be looking for where is that GHRH coming from somewhere else. Now, there's a couple of other little comments I wanted to make. Pituitary neuroendocrine tumors, we talk about tumor extent, we talk about proliferation markers. Some of you may have heard about this thing called Ki-67 in your pathology report. There may be a Ki-67 number, and there are some people who think that this is important prognostically. I have to say that I disagree with that, and I've given you a couple of papers as references because it doesn't seem to hold true. But I do want to talk about the importance of tumor extent. And this again comes back to what I started with in terms of terminology. If we start thinking about these tumors as tumors not as benign adenomas, we will do a better job of actually doing our homework in identifying the important factors that are predictive of prognosis for any given patient. And I think anybody in the room who's had surgery, and certainly Dr. Cusimano, I know he agrees with me on this, one of the most important things is tumor extent. A surgeon needs to know before they go in to operate, is this tumor resectable or not? And if it's not resectable, why? Where? How big is it? What is the stage? Now, in any other tumor in the body, we actually give this a TNM staging. And the surgeons have actually inadvertently already provided us with the groundwork for this because we had originally a Hardy classification, which was Canadian. We now have the KNOS classification, which built on that and gave us a really nice basis for establishing just from an MRI, how far gone is this tumor? What's the preoperative prognosis of success? So we need to start thinking about that because at the end of the day, that is the most important thing. When are you diagnosed? When you are diagnosed, is your tumor operable or not? Is there a likely chance of success for surgical resection? And the bottom line is, if you can't resect it, you can't cure it. We're now looking at long-term, lifelong therapy to inhibit the hormonal effects of this tumor, right? So that brings me full swing back to our first talk today, which is the only way to be able to get it before it gets out of that pituitary fossa is to have increased awareness of acromegaly so that we pick it up before the tumor is so big that we cannot resect it. So at the end of the day, we really are all looking like the importance of early detection is the bottom line, and that's where you all play a role, because as patients, you're getting the word out. And as I said, acromegaly is all around us. We just have to open our eyes and be aware and see it. So on that note, I will stop the formal talk, and if there are questions, I am more than happy to answer them. Oh, do you want it to be later? Absolutely. Okay, I'll answer questions later then. Thank you.